From the Leslie Dan Faculty of Pharmacy at the University of Toronto, this is the I'm Pharmacy podcast. And I'm Mina Tadros. Like a train moving at a fast pace, innovation can feel unstoppable. In many ways, the only path is forward. It's exciting and it demands our attention. And this season, we've really pushed the envelope on exploring why it's important and all the steps in the pathway of innovation. We have to admit, after all of these episodes, I am very excited about the future. But like all good things, we must take pause to ensure we aren't just drunk with the excitement of potential and hope. To end this season, we wanted to use the next 2 episodes to do just that. Pause and explore what we must and should consider as we create these new futures with innovations. Over the next 2 episodes, we'll delve into the ethics of access, thinking about who truly owns innovation and whether there are alternative ways to incentivize groundbreaking advancements. How do we ensure that these innovations improve inequality and not just worsen them? To ground our discussions, let's start with a story that seems to repeat itself time and time again. Let's imagine a revolutionary drug developed to treat a rare and debilitating condition. This innovation promises to transform the lives of those affected by the disease, offering hope where once there was only just despair. However, the drug comes at an astronomical price tag, accessible only to those with the means or the right to proper insurance or coverage. For many, this life-changing innovation remains out of reach, widening the gap between the privileged few and those who are unable to get access. This scenario illustrates just how deeply the innovation and the access to innovation is important. So despite the potential of this drug to heal, innovation can sometimes exacerbate these inequalities in our society rather than help resolve them and even the playing field. But this innovation isn't just a pharmaceutical problem. Consider social media as a really good example. Social media was originally intended to connect people, bridge distances, foster communities, help us share ideas. It was exciting. I really still remember the day in class. I was sitting in the back and I peered over someone's shoulder while they were on their laptop. Here I was studying in upstate New York, and they were logged into a strange website. What's that? I asked. Oh, this is just this new Facebook thing. Little did I know that this was going to change the world and the way that people live and communicate. At first, it was exciting. I thought information and news would be reshaped for the better. While it achieved these goals to some extent, it also introduced significant challenges. Social media platforms have been linked to misinformation, mental health worsening, and polarization in our very societies. So the same tools and innovations designed to bring us together are now blamed for driving us apart, illustrating exactly how innovation can have unintended consequences that have far-reaching impacts. I think it's important that we think through all of this innovation as we stare into a future filled with AI that has the potential to revolutionize industries, making processes more efficient, and even saving lives through advanced diagnostics and new genomic techniques. So in these last 2 episodes, we take pause and we ask you to proceed with caution. So join us as we ask ourselves, consider this. To kick off this conversation, I spoke with Dr. Alison Thompson, a bioethicist here at the Faculty of Pharmacy.
I am Alison Thompson, and I am an associate professor in the Leslie Dan Faculty of Pharmacy and the Dalla Lana School of Public Health. And my research is in the area of public health ethics, and I bring philosophy and critical social science to that. So I'm kind of a hybrid creature of academia.
So how do you pick areas of study, and which areas have you studied?
So I've done a lot of work on early on in my career looking at the role of the public in health policy making in areas like xenotransplantation where there are public health implications.
Yeah.
And then later I got involved in pandemic planning from an ethics perspective. So a lot of work around priority setting of, who should get vaccines first in an influenza pandemic.
Yeah.
And that led to an interest in looking at drug safety and effectiveness ethics. So post-licensure, what are the ethics of looking, even just choosing which which drugs to pursue those kind of post-market studies on, and looking at issues around vaccine hesitancy, for example, and how public trust in science itself and in the pharmaceutical industry can impact uptake of medications and things like that.
Yeah. So would you say that there's a general trust for science in when we think about it from the innovation lens? Like I imagine during the pandemic, there was kind of like a boost to the idea of science in some populations. I'm sure there's others that we also hear about that do not believe this is true. But there was a lot of I think people understood the importance of innovation and innovating new therapies, vaccines, whatever it may be. Was there a blind eye turn to certain issues because of how important people felt innovation should be?
That's a great question. I think early on in the pandemic, those of us who'd been doing pandemic planning for a long time saw this. Obviously, there was a huge need because of a serious lack of preparedness for an event like that to invest heavily in research and development for therapeutics and vaccinations for dealing with the COVID outbreak. And I think a lot of people were really excited that this surely would be the moment when people thought, let's innovate a new way to bring vaccines to the world and to do that in a fair way and in a way that's accessible to those people who are most in need.
Yeah.
And so it was really kind of disappointing to see that a business as usual kind of model ended up taking over, and we distributed those things primarily on the ability to pay the way that we do every day. And so I think there was an opportunity that we lost there to really apply some of the learning from past pandemics, but also from people who have been thinking deeply about, how to bring innovation to different parts of the world and to think about issues around fairness and how to distribute the products of innovation fairly, which it just didn't happen. And it was, not surprising, but very, very disheartening for a lot of people, I think.
So when you think about the innovation playbook that we currently use, and we've kind of in this season talked a lot about, science and then some sort of commercialization, and then usually a company either spurring from that or a company purchasing it and spreading it around the world. And that's like the model we've come up with. And people talk about the idea of companies taking risk. And so this is why there should be a reward. When you hear about that playbook, someone with your lens, what are the issues that kind of come top of mind as areas of concern?
So I think of innovation as one of these words that everybody talks about, especially in academia and in the tech sector in particular. But, we kind of use it unreflexively. We don't really think it's always thought of as a positive thing.
Very much so.
And in a very linear way, that you have a technological innovation. There's usually an economic rationality for bringing it to market or, for how we distribute it. But then, we've got what we usually presume is alignment between the person who's doing the innovation or developing the technology and the people who are going to use it. And I think we need to think more critically about how often that actually happens, because I think there is a move towards what people would call responsible innovation. But I don't know that we've thought enough about what that looks like. And it's still done in a very idealized kind of way. We don't really have a lot of empirical data to show that what we were calling responsible innovation actually works to level the playing field for people who are more disenfranchised and have difficulty accessing innovative technologies.
I wanted to further explore this idea of responsible innovation and the interplay between private corporate entities and our healthcare systems. So I spoke to Dr. Quinn Grundy at the Faculty of Nursing, who specializes in this very space.
I am Quinn Grundy. I am an assistant professor here at the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. I also have the privilege of serving as director of a World Health Organization collaborating center that sits here at pharmacy on governance, accountability, and transparency in the pharmaceutical sector. And recently, I have also taken a leadership role with a new collaborative center for climate, health, and sustainable care, which is an interprofessional for faculty initiative to tackle some of those issues.
Awesome. So the WHO Center, are they going to work on an acronym, or is it too much to, you just got to say the full thing every time?
You
could just do, you know what they do in trials, right? They just pick random letters and then they just make it fit. It's like, oh, there's a vowel here somewhere. We're just going to make it,
If you have that gift, you should definitely become a trialist.
But it's got to become, that's like a good talent. I don't have that gift, unfortunately. I come up with really bad names. So you're at a social gathering. People find out you're a researcher and professor, and they're like, hey, what do you study?
Mm-hmm. It's always a loaded question for me. I think I usually start with health policy. And then depending on the crowd, I'll also mention I am, in fact, a registered nurse.
Okay.
Many people can't quite imagine what kind of research a nurse would do. I don't know if pharmacists also find this, but we also run the spectrum of people from doing close to basic or clinical research through translational work, through to social science, humanities. When I say health policy, I think what I'm hinting at is I'm ultimately very interested in systems and structures and the conditions that have given rise to our current health system and the clinical counters within it. But if I'm feeling really comfortable at a gathering, I will explain that I think fundamentally I'm interested in the interactions between what I would call the medically related industry, which is predominantly pharmaceutical companies, medical device companies, health IT, infant formula, and others you can imagine, and our publicly funded health systems, the clinicians who work within them and their interactions with industry representatives, and then our processes for generating health evidence and the interactions that they have with industry sponsors, the interactions researchers have with industry and their individual relationships.
So how did you become interested in this?
So I was looking to do a PhD, having identified that research was how I like to spend a lot of my time, and found a PhD program at University of California, San Francisco that was in nursing with a health policy emphasis. And the supervisor I found, Dr. Ruth Malone, really has pioneered research in looking at the activities of a corporation, and in this case, the tobacco industry, as actually a vector for chronic disease. So when we think in epidemiological terms, to look not at the smoking or the smoking behaviors, but to understand the industry through its public relations, its promotional practices, its sponsorship of scientific research and shaping those agendas through litigation, through sometimes illegal activities, that they actually created and are responsible for an epidemic of, tobacco-related disease. And she started that work. So in the 1990s, a number of U.S. states went and sued tobacco companies. And in that litigation, the tobacco industry strategy was to flood them, the discovery process, with documents. They had warehouses filled with boxes, hoping the state's council would never find anything in that mess. But then the internet happened, and they put all those documents online. There's an amazing archive housed at UCSF. And people like my supervisor developed methodologies to study these documents. And this, I think, is one of the first places where we really got an inside look to understand the mechanisms of those internal company strategies that ultimately created very poor health outcomes and public health outcomes. So I've followed that thread, and I think in subsequent work, what we heard from clinicians is that they, often when they're interacting with industry, it doesn't feel like marketing. It doesn't feel like promotion. The industry representatives are in health facilities to provide in-service education, They are sponsoring continuing education through professional associations. They're providing sometimes support during clinical procedures for medical devices. Busy clinicians find it often quite helpful source of information about, as you said, the innovative new drugs. It's hard to keep abreast of changes, wanting to be kind of at the forefront of your field. And so clinicians, I think, hold things like education and continuing competence and learning, I think, very close to their hearts. And so in subsequent studies, we've explored all the roles that industry then has taken on in the education and support space. And again, thinking of it as part of that channel alignment, getting everyone to say yes. But I think there's the other piece of that is seeing that I think our desire for, our faith in innovation, the way our health system, our clinical practice, our regulatory systems are often oriented, there's a high value placed on innovation, on that newness. And yet health systems, publicly funded ones, are really quite busy keeping up also with business as usual.
Right.
And so I have noted in recent projects that with innovation, there are often important choices for health systems to make around how to equitably allocate resources, what kinds of activities to support. I think we've lived in a political climate that really emphasizes scarcity and people doing more with less. And we've seen an erosion of our publicly funded health system. And so around some of this innovation in health technologies, I think there are real gaps in the system, but decisions to outsource a lot of those activities to the medically related industry. And so I think starting from this idea of, what are the interactions between clinicians and industry in the day-to-day, and actually finding that industry is quite built in to our health system.
Right.
I started in the States. I came to Canada, found similarly that, every time a hospital procures a new product, it's often within that procurement contract that industry representatives will deliver the in-service of education. And there's a moment where, that makes sense, right? That no one knows the product better than the manufacturer. We're spending a lot for this. Let's get this value add. They will come to all the units across the 3 shifts. You might have 4,000 nurses to train. So they'll have an agreement that the industry representative will hit 80%. And they'll get a 5-minute in-service on the unit about the new bladder scanner. And so it becomes very routine. It becomes very mundane. But what we've shown in our work is that it really opens a door to have industry representatives have a presence within health facilities, to form relationships with clinicians, and to become a trusted source of information about clinical practice, even beyond those health technologies. And we've seen that grow so that, we have pharmaceutical industry reps providing a lot of continuing education, practice-based education. We're seeing for clinical research that, again, this is a source of funding, and particularly for trainees. And I think in our recent work, looking at biologics and other specialty medicines, which in some fields have been really a breakthrough and transformed lives, but we're seeing now a proliferation of these and a gap in our system around some of the clinical services that are required to safely administer and monitor these drugs. And again, an outsourcing. And it's hard to say which came first, right? Did the industry come in and offer these services? Did the health system offload it? Was it some combination of two in the moment? And again, an effort to create favorable market conditions and favorable regulatory conditions and get these products to the people who use them faster, more. But I think a lot of Canadians have a sense that we live in this universal publicly funded healthcare system, and we're finding that the medically related industry is quite integrated. We're quite dependent, and we're exploring the consequences of that.
So when it comes to like information as being a source, devil's advocate, like it feels logical, right? Like when your Apple iPhone is broken, you go to the Apple store, the person who sold it to you should know the most about that product. And so when you want to know about a drug or a new device or that technology, doesn't it make sense to go to the producer to be like, what do you know about this thing?
I think it depends what your question is and what you need the answer for.
Yeah.
So if you're a biomedical engineer and it's your job to be able to repair, service this equipment on site, then yes, going to the manufacturer to have access to something that you can take apart and the materials and the regulated information about how it works and the safety parameters, yes, that makes sense. What we're even seeing, though, in that space is that companies are coming up with service contracts that they are unwilling sometimes to train the engineers that work in the hospital setting so that a dependent relationship exists. And the hospitals are then not only procuring the machine, but also having to go back and pay for service contracts. So the company is the only one who can fix it.
Yeah.
Or if you're the nurse on the unit, in some ways, it could be helpful to have, a representative of the company tell you how to use the bladder scanner. But what you really need to know is, when do I use this? With which patients is it appropriate? How does this work within their larger plan of care, within the larger picture of the things that I have to do in a workday? How do I troubleshoot it in a clinical context with the tools that I have right here? And so a lot of it is actually very local knowledge. It's very expert clinical knowledge. And I can't speak for pharmacists, but I know historically nurses used to provide a lot of this education. But I think, while clinicians really value practice-based education, this is another thing that has been steadily eroded resource-wise. And so industry is providing an alternative.
From a pharmacy perspective, like, especially when some hospitals, like in the heyday, I remember training, and there was like, if you walked anywhere in the hospital, you could probably get a free lunch.
Yeah.
Before some of the hospitals shut this down.
Yeah.
There was like I just remember seeing just trays and trays of food being delivered to every unit in the hospital. And it was reps that were coming in.
Yeah.
And as a pharmacist, you had to know where the reps were, because you were probably going to hear about, why is this drug not on the P&T formulary? Yes. We just had this amazing lunch and the evidence is great.
Yeah.
And I got to say, the lunches were, some of these lunch, depending on the unit, like they were getting steaks and lobsters. It was pretty good lunches. Yeah. And so you would know that they were listening, and then you would hear about it. So you have this battle between, like, if you're in the pharmacy unit and your job is to be the drug expert, and there's someone else coming around who's getting their attention. Yeah. There is a tension there. Yeah. And so, and we had, there's processes. And I think that's why for a large piece that the hospital started saying, no, we can't do this. It's
a fantastic example, because I think in the moment, it feels like a value add. It feels like, great, this saves me time from going to UpToDate or whatever to do my systematic review. I can keep abreast of the field. I'm busy. We don't get, a lot of like fancy perks. We'll grab a bite. Like, it feels time saving.
And the residents get food. The students get food. They get education. They bring people together. And it's like, but to be frank, like in budget constrained environments, these are the perks and things that weren't going to come. And they're gone.
Yeah. Yeah. And yet, if you look at the bigger picture, how much time then is a pharmacist taking to then guard against information that doesn't maybe align with policy, practice, formulary, when you had a local expert all along, but maybe didn't come with the lobster lunch, right? Yeah. So I think what we're seeing...
But that expert also has very little time because they're underfunded.
Because they're underfunded.
And it seems to me like they pick spots where there is a lack of funding, and they fill that gap. And so the argument is that, are we willing to pay for that? Right? Because some of my colleagues will say, like, for some of the services that we're getting as a system, the patient support programs, the education, conferences. I've been part of committees that receive and planning committees that receive a lot of money from industry. And if they didn't have that support, the conference fees could be double, if not triple.
Yep.
And then students can't, and so the counter argument is like, well, that's fine, we'll stop. as long as everyone else stops, my competitors, we have a even playing field, but you're going to have to pay for all those things. And where's that money going to come from?
Yeah.
I found this idea of rethinking the innovation cycle really intriguing. So I spoke with Dr. Thompson more about where does the mandate fall and who are the key players in changing this system. We live in a world we had rapid globalization, and then now we're starting to see everyone pull back and build their walls on their borders. And each country's thinking of its own, and this became very apparent during the pandemic.
Yeah.
The global entities don't really have power to mandate anything. Mm-hmm. So if we do want to see change, or we want to see a better alignment of incentives and sort of proper conduct, who in our societies does this mandate fall upon?
That's a great question. I think I actually think in terms of global health research, there's a lot of potential there to think about. We tend to think innovation flows in one direction, but there's the possibility that if we were more open to it, that we could learn a ton from people in low and middle income countries, for example, about how to do things better or in a more innovative way, in a more sustainable way, and in a way that doesn't impact the climate in the same way. They don't have the same impact on the climate that we do in high income countries. So I think we should start thinking about innovation as going both ways, but that only happens when we kind of insist that high income country researchers partner in a meaningful way with researchers in low and middle income countries. So, I think rather than thinking up a research question and then going there and doing it and thinking you're helping, I think we need to start partnering in a more meaningful way with other scientists in other countries, capacity building in other countries as well. So that, I'm not saying that we should all develop our own vaccine manufacturing capacity in each nation, but in the absence of that ability to sort of engage in a meaningful global governance, and, there's a lot of speculation about whether the WHO even has a mandate anymore after the last couple of pandemics. It's people are really questioning how effective it is as a means of governing that kind of thing. I think there's probably a lot of work to be done in rethinking how we do this, getting away from that sort of helping mentality and more about supporting those researchers in other countries.
Absolutely. So where does academia's mandate fall? And just to give a little context, like this season, we've heard a lot about commercialization and handing off that innovation so it can scale upwards. And these are a lot of the themes that have emerged. But there was a kind of hesitancy to say that our mandate is to produce businesses or create businesses, right? There was just this idea that commercialization is a mechanism to scale and a mechanism to ensure viability of your technology making an impact on humanity. So from your perspective, when we talk about all these issues, where do we fit in? Where does the academe kind of fit into all of this?
Great question. I think that the more we go down this sort of neoliberal road of thinking about the instrumental value of higher education and research, the more we're going to see that commercialization being front and center, the more we're going to see a sort of consumer attitude from students about consuming education rather than, what was used to be about training young minds to think critically about the world that they're in. And, I think if we abandon that mandate, and we kind of, in many ways, think about our students as consumers all throughout the institution now. We count each student as a business income unit, they're not minds to be shaped anymore. They are economic entities in a way. I think it's pretty pervasive in the university. I think we have to fight against that. And that's not to say that all innovation is bad. It's amazing. It's done incredible things. But I think we have to be allowed to fail and to learn from those failures. And we need to create a culture where it's okay to do that. And I'm not sure that we reward that very well in academia. You know, the amount of research misconduct that's happening because of that pressure to publish, because of the sort of competitive environment we've created rather than a collaborative one, despite the fact that we talk about collaboration a lot, it's still pretty competitive. So, you know, these are great questions, and I don't know that I have any answers for them, but I think it starts with the mindset that we bring to the pursuit of truth, you know?
Yeah. In talking with Dr. Thompson and Dr. Grundy, it was obvious that the structure of innovations and their successes cross-cut a lot of other issues in our societies. With the current structure of innovation being so macro, we are focused to think about the big wins. But this machinery is not perfect and may leave people behind. This machinery presents opportunity to further think and imagine a way to optimize or improve so that we can ensure fair access, reduce bias, reduce potential corruption, but also ensuring that inequality is not made worse. On the next episode, we want to dive deeper into this. Who is left behind when the train of innovation doesn't want to stop or slow down? This episode of the I'm Pharmacy podcast was produced by Steve Southon, Kate Richards, and me, Mina Tadros. Musical accompaniment was from Steve Southon and Diego Martinez. This episode was edited by Steve Southon. Special thanks to Dr. Alison Thompson and Dr. Quinn Grundy. Just a quick reminder, make sure to subscribe to this podcast wherever you listen to podcasts. And if you don't mind, leave us a 5-star review. We'll be dropping new episodes every single month, so make sure to subscribe wherever you listen to your podcasts. Stay safe and keep asking questions. Catch you at the next episode.